Have you observed any biomarkers, Michael, that best predict a strong clinical response to LDN in mold or CIRS? And what key factors guide your decision to introduce LDN early in CIRS treatment versus after detoxification? It's specific to the mold presentation.
Lord, that is a loaded test-oriented question. There's too many to count. I would, if you're not familiar with reading inflammation markers in a test, utilize a company like a Vibrant America that gives you an educational piece so that you can see from everything from CRP to every IL marker, that you can see how and why their function will shift inside of utilizing something like LDN. You'll notice shifts in IL markers down regulating. So like, let's say you're lit up like a Christmas tree, things are gonna calm down fairly quickly. Our testing kind of prerequisite was like every 3 to 6 months. So 3 months on a medication, you can see a pretty significant shift in inflammatory markers. Do you have anything you want to add to that on the testing front?
Just from pure LDN perspective, Jared Younger, I always like to talk about the clinicians that we all respect and who've done some seminal work. Jared Younger found in fibromyalgia patients that the higher the SED rate is specifically, the quicker and more profoundly they respond to LDN. And I tend to see that with, really high, with my patients have everything. They're the quintessential everything patient that he discussed. They're coming in an absolute metabolic bomb because of the mold and that they're hypermobile and that they have, with their HLAs, they're the 25%, they're predisposed and they've had a TBI and, they've come to me after all of that, just like Michael would have. And if I find that their TGF-beta is sky high and they've got the HLAs and their SED rate is really high, and I'm like, okay, remediate, get them out of the zone, treat with anything that I absolutely have to treat. So I'm a microbiologist, so I am looking at their not only Marcon's levels. I have a veterinarian who also is a mold patient, and I have a lawyer who was in a sick building and a lot of stress, but they grew out some of the weirdest drug-resistant stuff with other molds and things that the veterinarian had some other exposures and multi-drug resistance because she was self-treating on top of it. So I've had to treat those things with lots of different treatments, but then using peptides and whatnot. But I find the more on fire they are with the SED rate, I feel like it's more white-hot inflammation with the SED rate rather than smoldering with the HSCRP. Sometimes you have both. It's not perfect, but I like to see that. And if I do, and I get them out of the zone and I treat, like I said, what I talk about, patients are going to be less reactive if you treat what you can. Get the low-hanging fruit. Also get them, get them into ketosis, get their blood sugar more stable, get their brains oxygenated, do what you need to do, and then get the LDN on board. Their SED rates come down pretty rapidly, and they tend to do really, really well. I absolutely say, look, there is so much that you can get from a CBC with DIF and a CMP, a SED rate, a C-reactive protein, which we've negotiated with our lab, that we can get even if a patient doesn't have insurance, vitamin D level, and sorry, Mark, I don't always get 125 dihydroxy D levels if they don't have any insurance, but I can negotiate for those costs, get a full thyroid panel, get basic hormone bloods, and I can tell so much about a patient and their physiology by those basic labs. And I talk about this, I can't remember who I was saying, we get really jacked and jazzed about the sexy stuff. You talked about so much sexy stuff. The Holtorf Clinic does really sexy stuff. That is the 10%. I talk about an iceberg. 10%, the sexy stuff, is the iceberg that we can see. 90% of an iceberg is underwater. So we all need to become physiologists and pharmacists and all the things that do the 90% not sexy stuff. In the LDN book 3, I wrote this chapter, and I did a TBI chapter in book 2, because I treat a lot of my patients as if they had a TBI, even if they didn't. Because the physiology is so similar when everything is on fire, gut's on fire, brain's on fire. But in the LDN book 3, I talk about deal breakers in treatment. Mold is one of them. Blood sugar is one of them. Blood pressure is one of them. You can't heal a brain if you're poorly perfusing, right? We glorify in medicine the low blood pressures, but that's pretty terrible if you've got a dysautonomic patient who is cold everywhere or extremely hypothyroid hypothyroid patient, right? So I talk about those deal breakers, and those are low-hanging fruit, and that's the non-sexy 90%. And so if you come from an impoverished community and patients don't have money to do the sexy stuff, so like that's really, really sexy and awesome, but not all of our patients can do H-bot or peptides, which I try to, like I'll do oral peptides and I'll do them for a month, but I save them for when I can get the best bang for my buck, right? And then I'll say, all right, let's do a month of KPV and lorazepatide and then BPC when you can afford it, you know? And I'll stack them and I'll do them in a really strategic way, but I'll save it. I'll do all the low-hanging fruit that I can, and I'll do the LDN and I'll get it for 20 bucks a month, right? They do much better, but you've got to be really strategic about it and employ the sexy stuff when you can, and if a patient can afford it, go balls to the wall and do all the things. It's awesome. You get them, they get them well quickly. Tons of limbic system work. You know, I'm going to shout out Galen Forster's work with his mental health patients, but really, you know, getting them doing different kinds of biofeedback and working on the traumas in different ways. I did some really avant-garde. I had 2 incredible therapists, and I'd been seeing therapists my whole life. Really incredible therapists that had me doing stupid stuff, right? Like EFT and humming and trauma work going back to my birth and all this other stuff that I never would believe in as an allopath. And I'm an evil allopathic doctor. I had to literally go after a break. I had a medical leave where I was in the middle of my residency, left, came back, and didn't believe in anything that I was doing. And I had to make a conscious decision to finish my training, apologizing every single day, writing my prescription from a heart patient for a statin and a low-fat diet, saying, I apologize. When I finish this, I'm going to do better by you. Knowing that if I could get my credentials, I could do this work and I could do better. But like I said, do the basics, learn the physiology, learn the patterns, and then you can affect change doing all the low-hanging fruit stuff.